Tell me what brings you into the office.
So I was working out at the gym
Yeah.
back in May, and I was squatting, and I think I squatted too heavy, and like I started to feel pain in my knee.
As you were going down on the squat or coming up, do you remember?
As I was going up.
As you were going up.
Mhm.
You felt it on the front of the knee, the back of the knee, or the side of the knee?
On the front, like right here.
Right there.
Yeah.
Okay. And that's the main reason you're here.
Right, that's the main reason.
Main reason. Okay. Now, let's watch you do a squat.
Mhm.
Again, please stand up for me. Just do your normal squat.
Okay.
Don't think so much about it. Okay. Do it again. So one of the things we need to discuss is when we're squatting, we mentioned it earlier, when we're squatting, we want to make sure the knee does not pass the toe.
Right.
Now, I want you to be mindful this time, do the squat, but don't let the knee pass the toe.
Okay.
Okay? And I'm just gonna, and watch as he's going down what's different. Okay. You see how his toes come up. I want you to try that again, making all your toes touch the floor. Don't raise them.
Okay.
And make sure that your knee doesn't pass your toe. Go ahead. It's harder, right?
Much harder.
And the knee is already passing the toe. So there's a couple of things going on here mechanically we need to figure out. Let's do one more, please.
Mhm.
Squat, very mindful that your knees don't pass your toes.
Okay.
Stop there. Come back up. Okay. And see his walk. Go ahead and walk for us. Now, what's interesting in this walk, in this case, is he does have that pelvic twist or wiggle, but it's different than what we've normally seen, okay? And here's what's different. I'm going to explain it with my hands, and you're going to just keep walking, okay? So, hold on. Let's just start over. Go left. Now, here's what I want you to see. These are his dimples here. Okay, and when we look at the dimples, the left side is a little bit higher, the right side is a little bit lower. Go ahead and raise your right leg, please. Keep the knee bent and raise it up all the way and down. Hold on to the wall so you're not tilting, please. And go ahead and raise your left leg and down. Right leg up and down. Okay, now go ahead and just march in place. Take a step forward, march in place. So here's what I want you to see what's happening. I want you to look at his pelvis here. And as he's marching, we do have the side wiggle going on, but it's kind of doing this too. It's rotating like this. So now watch what happens when I have him close his eyes. Close your eyes, and he's gonna start going forward. He's trying to catch himself. There's a short leg on the right side. Okay. Turn around and face me. Open your eyes. March in place. So when he's marching here, you can see he's putting all the weight on the back right heel. That's pretty significant when we're looking at his foot. Now, his knees, stop there, please. Good. When we look at his kneecaps, this one looks like it looks straight. So why is his foot rotating on that back side? That's the question. Is it coming from the pelvis? If it was coming just from the pelvis, then the whole leg should be rotated, but the whole leg is not rotated, just the tibia is rotated.
Right.
So that's what we're trying to figure, that's what we need to figure out. Your foot presents as just looking at you this way, presents as this is a pelvis that's out. But when we go examine it a little bit closer, it's not just the pelvis, there is that knee component.
Right.
However, you're complaining of your left knee. There's two things going on here. So we need to figure out, yes, you had that injury, and we're going to talk a little bit more about it.
Right.
But the question is, was this out first and it predisposed that because of the short leg as well, so mechanically we were off?
Right.
Or was that truly the issue and this is a result of that? That's what we need to figure out today. Okay, let's go over your x-rays.
All right.
Let's figure out where we're going to start. Come over here, please. Now, this is a picture in time. This tells me how you evolved or developed over the years since birth. I'm going to go over the basics of the full spine analysis. There's a lot of general information. That information is available in one of my videos, Dr. Rahim Chiropractic 101. And it's about a 55-minute video. I explain everything in detail of the general stuff, why we need to have 60-degree curves, what is the level foundation. We're going to go over that today. What happens as a consequence of not having a level foundation.
Right.
Right? Have you seen the video?
No, I haven't. Sounds interesting though.
It's actually one of the best videos in terms of knowledge, but it is probably the least viewed because there's no cracks in it. This is the A to P. This is looking at you from behind. This is right. This is left. This is the side profile here. We're designed to have 60-degree reciprocating curves on this x-ray. Now, before we get into the analysis, I want to mention something. We can see there's a kink here and there's some curve stuff going on, right? But people ask me, all right, so what do we got to do to straighten out this spine? That's not our business.
Right.
That's not my business. My business isn't straightening out a spine on this x-ray. When we look at this x-ray, we have healthy, perfectly healthy straight spines. We have perfectly healthy curved spines.
Right.
We have unhealthy straight, we have unhealthy curve. So this isn't the real status of the person's health, okay? But this x-ray is very important in the curve. When we lose these curves, it starts a degenerative process, right? And it can happen at any age. Now, let me be mindful of that. I'm not talking about an infant or a toddler, right? I'm talking like after 18 years old, or even in teenagers that I see, where they had an old trauma. That trauma started a process where if something is stuck, what happens? Other things have to compensate and make up, and they start to wear out unevenly. So the idea is figure out what do we need to do to put things in balance so things are working evenly or balanced. Does that make sense?
That makes sense.
Now, when we're looking at this, we said 60-degree curves. 60, 60, 60 is the magic number in terms of ideal.
Right.
Now, give or take a few degrees is fine, but we're going to go over more detail when we get to this x-ray. Let's get back to here. Okay? All right, so this work is based on the level foundation principle. Level foundation principle states in order to have a stable 24-story building, you need to have a level base and foundation. First thing we see here is we have a measured difference of 7. So we have a shorter leg on the right side. There's a 10 millimeter difference between right and left. What Dr. Gonstead found in his analysis and his work, as long as it's under 7, adjustments will hold. Now, there's a formula with the pelvic imbalance to see. He found for every 5 millimeters of pelvic misalignment, it can raise or lower the femur head. In your instance, I labeled the left side because we list the side of lowest lumbar body rotation. In your case, it happens to be to the left, but I have to find it on you. It may be the right pelvis, but in terms of just the listing, I've listed this side. Now, what does this mean? AS5, IN10. This is what's happening. So the left pelvis goes up. Now they work in opposite. One goes up, the other goes down. One goes in, the other goes out. Left goes up, so the bottom is down. Left goes in, so the bottom is out. And this is why you're standing on that back right heel, because of that short leg. Okay? Now, correction of the pelvis, we're going to be able to get it up 6 millimeters to about 4. So we'll be able to get it underneath there with the adjustments. Okay? If for any reason down the road, and if we decide we're going to go through and correct this stuff, I will re-x-ray you down the road and make sure we're under that 7 millimeters.
Sounds good.
Okay? If we're not able to for any reason, then a heel lift may be indicated to put in there. I don't see that right now. Okay? Now, so that's the pelvis. Now, you noticed I labeled something there, number 6. Typically, we have 5 lumbars, 12 thoracics, 7 cervicals. In yours, you have a transitional segment, and the transitional segment is your sacrum, or your S1, took on the characteristics of the lumbar. So it appears there's probably a little bit of instability in that low back. Okay. What does this mean down the road? It just means more back strengthening. Nothing to fix. Okay.
Okay.
But we'll get to that in a second. Now you're complaining of the left knee. Okay. And we have two issues here. We have the left pelvis and we have the left rotated sacrum. So follow the thought process. It goes up and in, and then the sacrum turns with it. Okay? So doing that, we're favoring to the left side. But because of this drop, you're counterbalancing it. If I have you walk, again, we're going to have you walk with your eyes closed. You'll appear to go left, but then you'll catch yourself because of that short right leg. Right. So that's the imbalance I'm talking about. When I'm watching you walk, there's
Is that why I get the
yeah, that's why it's not just the side wiggle, so to speak.
Right.
No pun intended. It's the side wiggle, but it's doing this too.
Right.
So that's what we have to figure out for you. If we get that stabilized, knee will come around. This doesn't get stabilized, knee just brought you in here.
Right.
Knee's not the knee.
So before the knee.
Before it gets worse, this is what we have to deal with. Does that make sense?
Perfect sense.
Okay, let's continue. Then part of the level foundation is this. If this is our level base or foundation, first one to come off is 4. 3 goes with it, 2 goes with it, 1 goes with it, 12 comes back to level. So what does that tell us? We have a potential L4. Next one to go off is 11. 10 goes with it. 9 comes back to level. Next one to go off is 8. You've had some good hits. You've had some good hits, wherever that was, whether it was in school or college or San Diego. You guys play rough down there, don't you?
Yeah.
Yeah, all good though. Now from 8, here's the cool thing I want you to see. From 8, this whole upper back, 8, 7, 6, 5, 4, 3 to 2. All of this is compensating, and you can see these side shifts. You had some good hits there. This is the area that controls heart and lung. This is the area that controls digestion. So I'm sure there's something off on the digestion. I'll let you tell me next visit after you actually get adjusted and things start.
If there's anything different.
If anything is different there, okay? So far, so good?
Yep.
Does that make sense?
Makes sense.
Okay. So on this, we need to stabilize the foundation through the pelvis, potentially the sacrum. On the side profile, now here's where we're going to put the pieces together and get some answers. This all started as an old tailbone injury. And that's what you need to figure out, okay? That's a significant, this should be a smooth curve. You got a big nub right here. I call it a nub.
Right.
It's a callus, and it's calcified. But the good news is you're still young enough that the sacrum doesn't completely ossify until 32, 34, around there. So I can still get in there and do some good stuff for you.
Nice.
Okay? So this is where it's all starting, down in the sacrum. S3, left side, potentially with the pelvis. That's just based on what I see here. Now, can we move up? Here's the good news. Your discs are great, dude. Your discs are fine. So we're looking at curvature because of some of this tilting. We're looking at the undersurface of the bone, but 5's good, 4, 3, 2. These are all good. This is a little dark in here, but if we're looking here, these discs are all good. Even going through here, even with this kink, the discs are still good. The only one thing I will point out is starting at around 5, here and here, it's rubbing a little bit, so there's a little bit of calcium building up there, okay? If you don't have any crackling in that area, when I start to adjust down low, things are gonna shift. You're gonna hear probably pops you didn't hear before, as you were saying, different from the neck.
Yeah.
And I'm gonna explain the neck in a second, okay? So far so good, makes sense?
Yep.
Okay, let's go up. As we go up, let's look at 7. 6 is good, 5 is good, 4 is good. 4 is tilted though. 4 is tilting back. Something happened there. 7 is also, but again, overall, they're all good. You've had several hits. Okay. C7, C4. I'm seeing they're tilted a bit. Let me just erase this. But you have a nice curve in your neck. I like the neck curve. So I'm happy with that.
That's good.
Yeah. But here's now the big take-home message, okay? Is you carry your whole upper body behind your foundation. Now you can see it just how he's like this. This is you. I'm making fun a little bit, okay?
That's fine.
This is you. So you have a decent curve in here. We could get a little more from fixing the pelvis as we get this curve, but here's what happens. From here, I did the laser level. And if we look at the laser level, this is like doing a plumb line. And in the plumb line, the line should bisect the ear, the shoulder, and the hip. This represents the hip. Now look where your shoulder is. You're back here. You need to be up here.
Oh, wow.
You need to be up here. So here's what I'm trying to explain to you. All of this needs to do this.
Come forward.
Yes.
Yeah.
And as that happens, you're not going to be happy because those muscles and ligaments have been like that for a period of time.
Right.
So things will shift. Your biggest thing you're going to do after today is walking. Not weights, not trying to do squats and all that right now. Just lots of walking, hiking, swimming, biking.
Yeah.
Best rehab for the spine is elliptical with the handles or cross-country skiing. You have access to one of those?
Yes.
Perfect. Okay? I'm keeping it simple. All right. There's no rehab here. It's just get out and be active as we put things in place.
Okay.
Okay?
Hiking.
Lots of hiking is fine. All right. Questions, sir?
No.
So we have a transitional as an old tailbone injury, and we have a rotated pelvis with a dropped leg causing the imbalance. You were doing a squat with improper form, improper mechanics. Something went out. Let's put up the knee x-ray. So let's talk about this. Doesn't mean we won't figure it out. You know, I heard a story that Dr. Gonstead, no one taught him. How did he figure it out? So the story goes that everything he figured out, like someone came in with a dysfunction or a problem, he first went to Grey's Anatomy. That's not the movie.
Yeah.
Okay? It was by Dr. Gray. So let's look at the anatomy of the organ or joint or tissue, whatever it is. Then he went to Gaitan's or the physiology textbooks. Let's figure out the physiology of that area. Now between the anatomy and physiology, he figured out how to fix this stuff. In the knee, I want to share this story. This is a cool story. Before Dr. Gonstead, it was illegal to touch the knee and extremities. He was also the first one to say that the pelvis moves. He was the first one to diagram and articulate the misalignment. He actually drew this because he studied over 200 cadavers himself after graduation. So at weekends, he'd fly down to Lincoln Chiropractic College from Wisconsin, and he'd be dissecting. And he wanted to really know these nerves of the anatomy. Okay, it's pretty cool stuff.
That is pretty cool, actually.
There's no doctor I know that's done that I know of. I'm sure that there may be out there, but in terms of the amount of cadaver studies he did. Now, what happened with the knee? He had a patient who hurt their knee, but it wasn't. So let's rewind. It was illegal to adjust the pelvis in Wisconsin, and before Gonstead, he diagrammed it, he showed it, and proved that actually these are movable joints, the SI joints. Okay. Then the knee, same thing. It was illegal to adjust the knee. What did he do? He had a patient with a bad knee. He wasn't going to let them go.
Right.
So he took a knee model and he put it up. He did an x-ray. And let me go grab the knee model. Dr. Gonstead was trying to figure out a knee. What did he do? He took the knee model and he shot an x-ray. Boom. And then he misaligned it this way. Took an x-ray, misaligned it this way, took an x-ray, misaligned it this way, just made different misalignments. And he came up with this, there's this marking system that we use for the knees as well. And the idea is this, we're first looking at wedging, okay? These are the capsules, so this is the medial meniscus, this is the lateral meniscus. These lines should be parallel, that's the first thing. When it's open or wedged on the outside, it's a potential tibia misalignment, according to the work. If it opens on the inside, it's a potential femur misalignment. So on both of these, we have lateral wedging. Now, here's the thing that's throwing me off. And let me do this. So I listed, it's actually PEX. PEX, bilateral tibias. That's not typical. So this has been there, or something else had happened, and this kind of went through a process. What do I mean by that? When we're looking here, so I'm looking at, this is the fibula, this is the tibia. There should be a gap there. You're superimposed bilaterally on both sides, meaning this. They're both rotated back like that.
Dang.
Okay? That didn't happen last year. There's no way.
Right.
This has happened over time. Now, if we go back to boot camp, any issues in boot camp?
Yeah, just I got a fracture in my pelvis while running
Left side.
on the left side.
Okay, so let's go to that left pelvis now and see. Now, that's the only thing you recall?
Yes.
Okay. Well, that's significant enough that threw some stuff off. And we'll go over that in a second. So we have bilateral PEX tibias. You're complaining of the left knee.
Right.
One of the things in the Gonstead work with extremities is rule number 1, never touch an asymptomatic knee. Okay, that's rule number 1. So even if the right looks worse, if it is not symptomatic, rule number 1, general considerations, do not touch an asymptomatic knee. So we're going to address what we find on you. Yeah. We're going to address what we find on you. And then I don't know that we're going to do the knee today. We're going to see how it does after the adjustment.
Right.
Okay? Questions? Nope. Let's get started. All right. So we're going to start on exam. You tell me when you're ready, okay? So what just happened?
Lightheaded, nausea, heat.
Do you get that a lot?
No,
When was the last time you had this?
maybe like 6 months ago.
What were you doing 6 months ago when this happened?
I don't know.
You're working? You're at home?
I think I was at home. Sorry.
No, you need a break?
Yeah.
Hey, Doctor.
How you doing?
All right.
Okay, so I want to go over a few things. We started your first visit a couple weeks ago, a few weeks ago.
Right.
And in the middle of it, we had a little situation. Can you tell me what happened?
I started to break out in a sweat and like kind of collapsed, and then went over to the urgent care.
Now, have you had that before where you just kind of wanted to collapse or faint?
Yes, maybe like a year and a half ago.
Okay, and do you remember what triggered that? What was it?
Nope, I was just standing in line somewhere, and then all of a sudden, the same thing happened. I started to sweat, and I had to sit down.
Okay. All right, and so what happened, guys, is right before we were about to start his exam, I just finished going over his x-rays. He kind of wanted to faint or pass out, and we just had to stop everything. And it wasn't about trying to wait for him to receive an adjustment at that point. We sent him to urgent care. They ruled out there was nothing serious going on.
Right.
I'm assuming, yes?
Right.
And you're back to where you were.
Yep.
But we still haven't done anything. So we
Right.
got to figure out some stuff. I want to recap on some things we went over on your x-ray. Okay, and then we'll get right into the exam.
Sounds good.
Sound good? Okay. Lateral film, AP film, looking at you from behind. This is the foundation. A couple of things we noted. Number 1 is we have 6 lumbars, right? Transitional segment, where this is called lumbarization of S1. Okay, and what happened is in this scenario, S1 is taking on the characteristics of the lumbar spine. And what we talked about with that is down the road, we need a little bit more back strengthening once we get things stable.
Right.
Yeah. Now, let's go over your foundation because there are some significant things here. Number one, we know we have a altered pelvis on the left. And so what we did, we have an AS5 IN10, which means what? Left pelvis goes up. So if the left goes up, the right goes down. They work in opposite.
Right.
Left is up and in. So the pelvis is favoring to your left side. The sacrum also has some rotation to that left side. So your foundation or your pelvis wants to go left, spine is going kind of to the right slightly. Okay? Does that make sense?
It does.
All right, so we know we have a foundation issue. We talked about an old tailbone injury, right? Down at around S2, S3. In this case, we'll subtract 1. So if it's S3, it's really going to be S2 because we have L6 there.
Right.
Okay. We're going to figure out what we find on you. This was the other significant thing. We have a leg length discrepancy. We have a measured difference of 10 millimeters. Now, according to the Gonstead work and the formula of the misalignment of your left pelvis, by correcting, if we're able to correct all of this, we're going to be able to get this up to about 4 millimeters. And what we said is in this work, we want this under 7 millimeters for the adjustments to hold.
Right.
Okay? Now, as we go up, we pointed out we did the level foundation principle. We found a few majors on the x-ray. We found 4L, 4th lumbar, 11th thoracic, 8th thoracic, and then 1st thoracic. And we talked about there's a kink going on in here. And did we ever figure out what that was?
No, I remember you asking me, but I don't have any recollection of anything happening.
And maybe something in the military, maybe not.
Maybe not.
Maybe not. It was, how was boot camp?
Rough.
Rough, but you made it, right?
Made it through.
Okay. So we can't get into all those secret ops you went on, but I'm joking, guys. I'm just joking. But this kink is also significant for what? For the stability of the upper back and the neck. Yes? On the lateral film, the biggest thing we said was what? Your foundation you carry. We're going to use the laser level. And we're running it through the base here, L6. And what we saw, this plumb line should go through T1. And yours is up here.
Right.
Those muscles are working a little bit harder than they need to.
Right.
Okay? Questions on the x-ray?
No.
Okay, that's good. Anytime, through the process, just let me know.
Okay.
Okay, let's get started. And we're starting at the base of the neck. Now, with all that, what are you feeling today?
What am I feeling?
Yeah, what's going on today?
Like, as far as what?
Why are you here?
Oh, to continue from last time, like, I'm having some knee injuries. Not injuries, some, like, problems with my knee.
So we went over that too in terms of the knee x-ray and the alignment. We'll assess the knee.
Right.
The right one looked worse on the x-ray, but as we said, rule number 1 is never adjust an asymptomatic knee.
Right.
Okay? So I'm getting about 8, 9, 10 points of pressure at the base of the neck, C7. Top is fine. Yep. Base of the neck, C7. Around T9, T10, left side. All right. Sit up a little straighter for me. And it's left knee, and we know there's a left pelvis and a left sacrum issue.
Right.
So first visit, we're probably not going to touch the knee. We're going to address, like we said, the foundation. And we got 15 points down low. We're on S2, S3. Let's go ahead and statically palpate now, please. All right. Now, as we're running the fingers along the spine, we can start to see changes happening here around T6. You can see the swelling here now. And then you can see the distinct change right there, the orange peel right there. Right there. More tender there or there?
There.
How about above?
A little even more.
That one or that one? That one.
That one.
Yeah. Head down, please. Let's count. 7. 1, 2, 3, 4, 5, 6, 7, 8. That's 10. That's 11. 11. Yeah. Okay, let's continue on down low. Scoot forward, please. Feet together. Open and close the knees. We're checking general motion of the sacroiliac joints. Open and close. Open and close. Good. Right side only. Left side only. Right side. Left side. So his is a little misleading here. When he's doing the right side, when he's doing the left side, it's the sacrum wants to shift with it on the left side, but the right side is fine. When he does the right side, do the right side only. The whole thing shifts, but it's subtle. It's like it feels like more the sacrum is the issue. Scoot back for me, please. I have a feeling we're going to start on the sacrum today, not the pelvis. We've got to get sacrum loosened up first. This is L5. That's that L6 or S1, okay? A little tender there?
Right.
Yeah.
Yeah. It is.
Let's go down. S2. Starting there. You feel that one?
Yeah.
That's S3 on the left side. Now, there is a pelvis issue. That's not where we're going to start, though, today.
Right.
We're going to start on the sacrum. Now, the interesting thing, this actually goes against the chapters. In the chapters, the Gonstead chapters, when you have a rotated sacrum on the side of an ASIN, the chapters say if you have an ASIN major, you go for the sacrum. I'm going to take that back for right. Stand up for me, that's luck. So, according to the chapters, let's regroup on that. Page 43 of the chapters. When we have an ASIN, IN or an AS, and we have that on the same side as a rotated sacrum, we want to do the sacrum first. And in his case, it actually matches up there. Walk on your toes, please, up high. Turn around, walk on your heels, please. You can see that big shift there when he walks. In that middle of the spine. Regular walking, please. You can see him the way he walks. He swings the leg out. Okay? Watch his legs when he walks. Keep going. So, we want him to have a good heel strike when he actually walks. He has a, if we look and compare left to right side, keep going. So he's on that back right heel quite a bit. And that's from that dropped leg on that right side.
Right.
Okay. We're going to start with T1, base of the neck. We're going to set T1 as a PLS. We're going to set T11 as a PRI, and we're going to set S3 slightly rotated on the left. Sit up straight, scoot to the right a little bit, please. There you go. Left hand up. You good, right?
Yep.
All right. Nice and easy there. T1. Left ear down. And he's pretty flexible. We can go all the way. Gotcha. Home run. Stand up. Let's walk it off, please. And let's go on the gray table, face down. She's going to hold your legs just so they don't fly up. S3. Now, deep breathing, please. All the way out. Now, can you bring your hands out? Good. Deep breathing. Deep breathing. Relax your shoulders. Yeah. Gotcha. Good stuff. 11. 11 we're going to set as a PRI. Gotcha. You okay there?
Yeah.
Not bad, right?
Right.
Not bad. Walk 3-4 times back and forth. What's different right now as you're walking?
I can't tell.
Back over here, have a seat, let's recheck. Got a little bit of chatter going on here at T1. T1 is clear. You're going to need to do lots of icing, okay, today?
Okay.
And I'll give you the instructions of where. T11 is clear. S3 is clear. Scoot forward. Let's check the motion in the low back. You remember what S3 felt like, yes?
Yes.
Back slowly towards me, please. All the way back. That's 5. That's 6, or S1. That's S2. Good. That's S3.
Oh yeah, that's different.
Definitely. We're going to talk about it and need to work on some core work with you as well.
Okay.
You can feel that now, right?
Right.
It's moving better. It's less sharp, I'm assuming.
Right. I don't feel any sharpness at all.
Okay. Good stuff, dude. Scoot back for me, please. All right. Ears. Shoulders over, around. Let me do the work.
Mm-hmm.
There you go. Over, around. Let me do the work. Let's go on your back, please. I'm going to check your feet. Now, I will work on your ankles if they're out. Hold on. Yep. Sit back, please. But we're not touching the knee today. Your homework for the knee. Backwards pedaling. You have access to a bicycle?
I can.
Yep. Pedal backwards every morning, 5-10 minutes every day.
Okay.
And that's just going to help reset the Q angle. Which will make things easier down the road if and when we actually have to adjust the knee.
Okay.
AS talus bilateral, drop the fourth metatarsal head. There you go. Go ahead and sit on the floor against the door, please. Okay. All good in your sitting position?
Mm-hmm.
Go ahead and stand up. Okay. One last seat over here, and let's recheck. All clear. Questions for me today?
You're talking about a stationary bike, right?
Stationary bike, if you have a regular bike, just put it against the wall and pedal backwards.
Okay.
It's not about the resistance, it's just the motion.
Okay.
If you're going to the gym right now, no weights, just walking, cardio, swimming.
Mm-hmm.
You can do elliptical with the handles, go for hikes, things like that.
Sounds good.
We're going to regroup in a couple of days,
Mm-hmm.
and we'll continue from there.
Okay.
Okay, stand up for me, please. Squeeze my hand, squeeze hard. Squeeze hard. A little bit on the elbow, radial head, distal radius. Squeeze. Ulna, posterior, relax the elbow. Good. Posterior distal ulna. posterior lunate, posterior lateral scaphoid. There you go. Go like that 5 times, please. Squeeze hard. Squeeze. Good. That's where we're going to start.
Awesome.
Okay, I'll see you in a couple of days.
Okay.
Water, walking, and ice.
Sounds good. Where do I
Wherever I adjusted you, T1, T11, and S3. They'll give you an ice pack to start on the low back today. Walk for about 15-20 minutes before you drive off.
All right.
Welcome to the office.
Thanks, Doug.